دكتور اسلام، السلام عليكم. يا اسلام، جماعة الأمريكان دول الثانية يعني داخل معانا دلوقتي أستاذ من هارفارد، بس هيبدأ 6 بالظبط.
لا 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 امسك المروان، انا عندي حاجه بضرب فيها.
يا اسلام. اسلام.
مش همسح حضرتك ثواني بس، هو ثواني واحدة.
طيب ماشي. نعم.
احمد.
ايوه يا اسلام انا معاك.
اوكي خلينا اشوف بس دكتور مايكل موجود ولا ايه. هو احمد لسه ما دخلش. يا احمد ماشي، ثانيه واحده.
ازيك يا احمد، اخبارك ايه؟
انا يا دكتور هشام، ازي حضرتك؟
الحمد لله.
Society of Radiology and Nuclear Medicine and the Radiology Society at Bενها University. It's my great pleasure and honor to represent Dr. Michael Lev. Dr. Lev is the professor of radiology at Harvard Medical School. He also acts as the director of emergency radiology and emergency neuroradiology at Mass General Hospital. Dr. Lev is the deputy editor for neuroimaging of the journal Radiology from August 2007 till March 2009, for which he continues to be a special consultant deputy editor. He's also from the editorial board of the American Journal of Neuroradiology since the year 2000. And today, Dr. Lev is going to give us a lecture about advanced CT and MRI for stroke treatment selection, current practice, and future directions. It's a great pleasure having you, Dr. Lev, with us today.
Great, thank you, Ahmed. Much appreciated. Just to be clear, should I do a full hour speaking? Should I leave a few minutes for questions? Just what is the ideal way to time this?
Whatever suits you. Usually it's like 55 minutes and we leave 5 minutes at the end for questions. Or if you want the questions to be in the middle, whatever suitable for you.
Yeah, I think if there's anything important that people want to ask, that's fine. Otherwise, I'll leave a few minutes at the end for questions.
Okay, great.
So I'll go ahead and get started. And as you can see, this is actually a talk that I have given just a couple of weeks ago for MRI Online, but it's really always changing and always adaptable to whoever I'm giving it to and whatever audience. And actually, one thing that would be very useful to know is in terms of this audience, what type of equipment are you using right now? Do you have dual energy CT scanners? Do you have MR scanners in your emergency room? Are you doing CT with CTA on everyone? Are you doing CT perfusion on everyone with stroke? If I kind of understand how you're doing it now, then I could tailor the discussion that will be the most useful for you. And I guess if someone wants to unmute and I see that someone said CTA and MRI, and I guess So you have CT with CTA, but without perfusion. Great. Good. Perfect. Then that is absolutely how I will tailor this talk. Let me ask one other question. Do you have dual energy CT?
Yes, we do.
Okay. Okay, good. All right, that's perfect. So, earlier this summer, I was at a photon counting CT meeting up in Geneva, Switzerland. It was one of the first trips I've taken in 2.5, 3 years due to COVID. And CERN, of course, is where they have the Large Hadron Collider. It's one of the particle accelerators. And it's where they discovered the Higgs boson. And the reason there was a medical meeting at CERN, and specifically a CT meeting, is because that is where they actually build the detectors. And these are my friends Raj Gupta and Aaron Sodikson, who are the chiefs of radiology and ED radiology in the MGB system. And the reason the meeting was at CERN is because they use the same technology for medical imaging that they use to do these detection of these subatomic particles. And basically, photon counting CT is going to be a big advance over dual energy CT because it will have greater spatial resolution, better temporal resolution, better contrast resolution, and in fact, why is it that we use iodine as a contrast agent? We use iodine as a contrast agent because iodine has the K edge of about 30 keV that is close to the X-ray beam energy of a standard 80 kV CT, which is why we do CT perfusion at 80 keV. And if you're not already doing CT perfusion at 80 kV, you should, because not only is it less radiation as the square of the kV setting. So going from 140 to 120 to 100 to 80 kV reduces the radiation dose to the patient dramatically if you're doing CTP and going to be getting repetitive images. But also you get better images at 80 kV for CT perfusion because you're closer to that K edge of iodine. An 80 kV X-ray beam has a mean polychromatic energy, an average polychromatic energy of 40 kV. And when you're that close to the K edge of iodine, 40 versus 30 kV, the stopping power of the iodine is very great. That is why iodine is the ideal CT contrast agent for intravascular use. But with photon counting or spectral CT, like with dual energy CT, we could actually tune the scanner to be sensitive to whatever kV we want. And so it maybe means that something like gold, which is used to treat rheumatoid arthritis, other agents may be useful to use as contrast agents. So photon counting CT could be a game changer. It's just coming out now. It has FDA approval in the US for the Siemens scanner. And I think it's something that we're going to be hearing a lot more about. And as people use up the useful life of their CT scanners and buy new scanners, I think we're going to see a trend towards the photon counting CT being the standard. So I did want to introduce that. I also want to say that even if I lose the internet signal right now, most of what I'm going to talk about is in this 2019 radiographic special monograph issue of emergency neuroradiology. And specifically, we had a chapter on that is a stroke code how-to CT primer. And it really, just like you guys said in the chat just now, we really emphasize CTA as being one of the most useful modalities. And you can see here, that's page 1717. 17, by the way, is my favorite number. We could discuss why at another date. but this 2019 Radiographics Volume 39 has that stroke code primer that you could download for free from the internet. And so even if you lose the rest of this talk, you can pull out that radiographics review and have a good sense of the how-to that I'm going to be talking about. And just as kind of a very quick thing to bring everyone up to speed equally, stroke is a clinical syndrome. It's the clinical syndrome that results when you have a lack of oxygen, usually due to a lack of blood flow, but it could be from drowning. It could be from anoxic injury. It usually is an arterial embolus, but sometimes it's a venous stroke. And basically in adults, and we define adults, someone over the age of 40, the biggest causes of stroke are carotid stenosis and cardioembolic stroke. In Asian populations, and I guess Egypt falls somewhere in the middle between being Asian and Western, but in Asian populations, you see a lot more moya-moya. You see a lot more intracranial atheromatous disease and inflammatory intracranial vasculitis. That's not so much in Western populations and in Western diets. Now, we've gotten very good at reducing the rate of large vessel carotid stroke because of screening and prevention, but cardioembolic stroke, usually from atrial fibrillation, is harder to predict. And it's harder to predict because people could go into AFib and then get a left atrial thrombus, and you can't predict ahead of time who's going to go into AFib. But I will tell you one big clue on the imaging, especially if you're doing your CTA stroke imaging all the way down to the great vessel origins and getting part of the mediastinum and getting part of the chest, is if the AP left atrial diameter is over 5 centimeters. You'll almost certainly be in AFib or have some atrial arrhythmia if you have left atrial enlargement. And even over 4 centimeters, it's more likely than not that you will be in AFib if your AP left atrial diameter is over 4 centimeters, more so in the elderly. 80% of all strokes could just be prevented by controlling hypertension. And of the strokes of unknown origin, a lot of them are small vessel lacuna from hypertension. A lot of them are arch disease. But always, when you're getting your CTA, it shouldn't just be head, it should be arch to vertex, and you're looking at those great vessel origins. Now, those are in adults over 40. In young people, dissection is a lot more common as a cause of stroke. Spontaneous dissection. Traumatic dissection, of course, could happen in any age group. And also, you want to look for more congenital things, like a paradoxical embolus through a patent foramen ovale. And I like to look for keywords in the history. You know, one of the big problems radiologists have is that we don't always have the clinical correlation. And so when I see in the reason for study field on our PACS viewer, the word chiropractor or yoga or even honeymoon or weightlifting, I wonder if there's traumatic injury to the carotid artery that could cause a dissection, especially with the chiropractors. The same thing is if I see something that like says transatlantic or transpacific, a long plane flight where someone is sitting and may develop a DVT and has a patent foramen ovale and may have a paradoxical embolus through that patent foramen ovale, I worry about that stroke mechanism causing an embolus. So those are the key words, those are the clues I look for in that. And again, how big is the left atrium is something you could even find on a plain film. You know, if there's a bump where the left atrial appendage should be, there's usually left atrial enlargement. If there's, the carina should usually be 60 to 90 degrees, the carinal angle. If that carinal angle is over 90 degrees, then you want to worry that there's left atrial enlargement, and left atrial enlargement correlates with there being a high risk of atrial fibrillation, and a high risk of atrial fibrillation correlates with thrombus formation in the left atrial appendage and an embolus. So that's how we should go, I want to talk basically about arterial stroke. And you did say you have MR available at many of your hospitals. So MR, diffusion weighted imaging, is the standard of care for stroke detection, acute stroke, cytotoxic edema. You're going to see restricted diffusion, dark on the ADC, dark on the apparent diffusion coefficient images, but very bright on the diffusion images. And that usually, if you see that restricted diffusion in arterial distribution, that short of doing a flumazenal PET study, this is the operational reference standard for stroke detection and for estimating stroke volume. Why is it important to estimate stroke volume? It's important to estimate stroke volume because in a stroke treatment, and we're going to get into treatment in a minute, you want to look at the size of the infarct. And diffusion has the best signal to noise. It can give you the best volume. And we all know that 50 to 70 mLs, based on the clinical trial, is the upper limit for likely good outcome for doing both late intravenous thrombectomy or late arterial thrombectomy. And so basically, there are a lot of potential other causes of low ADC restricted diffusion other than acute ischemic stroke. And you could see it with dense cell packing from like lymphoma or small cell cancer. Lung mets are very common. 80% of the time when you see a met in the brain, it turns out to be a lung cancer met. That should be first on your list. If you think you see a brain met, get the chest CT. Other things like heroin leukoencephalopathy, Yakov-Creutzfeldt disease, any pyogenic brain abscess, a brain infection with pus has restricted diffusion and could have low ADC. So how do we know it's a stroke? Is it in that arterial distribution? And what is the clinical context? Was it acute onset? If you went from being totally normal to being hemiparesis, can't move your arm and can't speak, sudden onset hemiparesis and aphasia, we're talking about a stroke. And so if you see restricted diffusion in that setting, that's what you're thinking of. But in addition to a lot of these diffusion stroke mimics, like deep gray involvement from CJD, Yakov-Creutzfeldt disease, from hypoglycemia, from seizures, from basically herpes type virus with mesial temporal sclerosis here, lacunar disease, dissection could give you a basilar artery perforator infarct. But if it's diffuse and not focal, you should be thinking about things like osmotic myelolysis, central pontine myelinolysis. So there are a lot of stroke mimics, and that's one of the reasons it might be useful to do CT perfusion imaging, not so much because it's essential to make the treatment decision. You can make the treatment decision just off the collaterals and the non-contrast CT, and we're going to spend a lot of time talking about that. But CT perfusion shows you a web-shaped deficit, and it's helpful to show if there's a big flow deficit, because that tells you you're dealing with an embolic stroke, and that really is going to be different from a lot of these other causes of seizure. And stroke mimics are actually more common than stroke. So one of the advantages of CTP is to just look for a perfusion deficit, but we don't necessarily need that information to make a treatment decision. And here's a good example, again, from my friend Jeremy Height. Jeremy was a resident and a fellow with us, and now is the acting chief of neuroradiology at Stanford and the chief of interventional neuroradiology at Stanford. And what he showed here is that getting a CTP could be very helpful if you're a small community hospital in their network to know if you should transfer a patient for thrombectomy, because just the size of the perfusion lesion tells you whether you're dealing with a big proximal M1 occlusion or a more distal superior division or inferior division M2 branch occlusion. And basically, that is important also because some infarcts if they're not in an arterial pattern, might be cerebral vein thrombosis. So when you're getting your CTAs, you should always get delayed images, especially in the head, to make sure you see the veins filling. Because any infarct of unexplained distribution anatomically, or any infarct where you don't know exactly where the arterial distribution is, and it doesn't seem to make sense from any of the arterial stroke mechanisms we talk about, you should always think of a venous infarct. And venous infarcts could be a big cause of stroke, but in a way, because of the mechanism is venous hypertension causing outflow obstruction. And so you don't get as much that acute onset. It's more early vasogenic edema and ischemia and outflow obstruction without necessarily a core infarct. So you have a little longer to diagnose a venous infarct. And by the way, I'll tell you one more thing about venous infarcts before we go to the next slide. Paradoxically, a venous infarct gets treated with heparin, because even if it's a venous infarct that's hemorrhagic, and a lot of venous infarcts commonly have hemorrhagic conversion because the little arterioles and capillaries rupture and become friable with the prolonged ischemia. Even if there's hemorrhagic conversion, the treatment is to reopen the outflow, and that you would treat with hemorrhage. Because the blood is on the venous side and not under arterial pressure, reopening that vein does not make the bleed bigger. And paradoxically, the treatment is heparin. You would never want to treat someone for hemorrhagic conversion of an arterial stroke with TPA or with heparin or with a clot-busting drug, because it will make the bleed bigger and worse, because it is under arterial pressure and it's on the arterial side of the circulation. So again, we already said that DWI, short of doing a flumazenal PET scan, is the operational reference standard for dead brain. And why is that volume measurement important when we're saying who's likely to have a good outcome and who's not? It's because basically it's been shown reproducibly in pretty much every single major clinical trial that once your stroke volume is over about 50 to 70 mLs of dead brain, you're exceedingly unlikely to have a good outcome. Now, be careful here, because just because you won't have a good outcome does not necessarily mean that there's no benefit of treatment. And the clinical trials that said that late thrombectomy works or thrombectomy works, catheter clot retrieval works, those clinical trials were designed to show if the catheters help and if the treated group has a better outcome than the untreated group. Now, it may be true that if the stroke is over 50 to 70 mLs, both the treated group and the untreated group are unlikely to have good outcomes. But the logic is that that still doesn't mean that there's no benefit of treatment. And even if they don't have good outcomes, the treated group, in a lot of subgroup analyses of these trials, still has better outcomes than the untreated group. And the modified Rankin score, the MRS, is a 6-point scale with 0 normal, 1 almost normal, 2 okay, but some disability, but able to work. 3 means disability and maybe not able to work. 4 means very sick, needs nursing care, home care. 5 means stuck in a hospital with really outgood function, and 6 means dead. So if you could take a patient with treatment that would have been a 5 or a 6 and make them a 3 or a 4, that is still a benefit of treatment. And so be careful, because not everyone always sees that logic. And that is the danger of using perfusion imaging, because unlike diffusion, perfusion imaging does not measure dead brain, does not measure core. And in fact, precise use of terminology is critical. One way in which we could define this is that when you see a lesion with restricted diffusion, it means dead brain, core infarct is likely, even if you were to immediately reopen that vessel. Infarct is likely despite immediate reperfusion. Whereas if you see a severe malignant blood flow deficit, very big reduction in blood flow, it still doesn't mean that infarct is definite. What it really means is infarct is likely without immediate reperfusion. So I don't know if any of you have ever driven Boston and see the people who drive in Boston, but it's kind of like a traffic light in Boston. When you see a red light, it means stop, don't treat. When you see a green light, it means go, treat. And when you see a yellow light, it actually means, in Boston at least, go fast. And it's kind of the same thing. When you see a perfusion deficit, but the DWI is normal and you're not seeing the infarct on the non-contrast CT, then often, not always, but often it's possible to treat that patient even with a big perfusion deficit and save a lot of that brain that has not infarcted yet. So remember, perfusion is not infarction. Diffusion is infarction. And this was our protocol to get a non-contrast CT, a CTA, and a DWI, or if we can't get a DWI, to get a CT perfusion. And that was our protocol since 2000, for over 20 years. That was our protocol. But really, for a long time, the standard of care was only the non-contrast CT. And it's important to note in this protocol that getting the non-contrast CT should never delay treating with IV TPA if the patient is eligible. And so with us, it's easy because we get the non-contrast CT, we check it at the scanner. If there's no bleed, which is the only absolute contraindication to treatment, we go ahead and get the CTA while they're mixing the TPA. And IV TPA takes 5 to 10 minutes to mix, and we could finish the CTA, and if needed, the CT perfusion imaging beyond that. And that protocol was written up in Journal of JNIS in 2013 from Dr. Gonzalez in our group. And again, we've been doing it this way dating back to 2000. So to us, this isn't new, but it did not become the standard of care until 2015, when you had 5 big articles, all published over a short period of time in the New England Journal of Medicine, that all showed that intra-arterial therapy works with proper patient selection for treatment based on imaging. Now, it's very interesting. I'll just take 1 minute and say as an aside that they tried to do these studies in 2013, 2 years earlier, and there were 3 big papers all published in the New England Journal that failed to show a benefit of intra-arterial thrombectomy. Why did those papers fail in 2013 when papers worked in 2015? And the answer to that is 2 reasons. Reason number 1, and likely the most important reason, is that the 2013 trials used 10-year-old catheter technology. And the catheters got better over that time period. And when they repeated the trials in just 2 years, between 2013 and 2015, they used the new modern stent retrievers, penumbra devices, clot retrievers that were more efficient. That is one big reason. But I'll tell you the other big reason. The other big reason the 2015 trials worked and the 2013 trials didn't is that the 2015 trials became the standard of care for using advanced imaging for triage. Most of the 2013 trials that failed only used non-contrast CT. They did not use CTA or CTP or DWI. Some of them did, and when you looked at the subgroups, those subgroups that did had a possible signal of benefit. So it wasn't until the new trials that used CTA as the standard of care that they got a positive result. because they were making more precise selection of who would benefit and who wouldn't benefit. And in fact, Raul Noguera, who was one of our old residents and one of our old fellows, later on got his attending job as the chief of neurointerventional radiology down at Emory University in Atlanta. He took our MGH imaging protocols for stroke with him, and he not only applied them 6 to 8 hours, the way the 2015 trials did, but he said, let's try doing the same thing up to 24 hours. And you know what? It worked. If he measured core less than 50 mLs and looked for a good collateral pattern with clinical core mismatch, up to 24 hours, it was safe to do clot retrieval with catheter thrombectomy. And that, of course, is the famous Dawn trial. And it wasn't until that trial that came out and was widely publicized in very early 2018 or at the end of 2017. It wasn't until then that CTA for acute stroke imaging became the standard of care. And I'm glad to hear that in the chat, you all indicated that you're all doing CTA, because that's the standard of care now. And very short behind that, up to 16 hours, the Dawn Diffuse 3 trial showed the same thing, up to 16 hours. So the take-home message is that it wasn't really until 2018 that CTA became the required imaging standard of care in the selection of acute stroke patients for intra-arterial catheter thrombectomy. And so glad to see you're all doing it. Now, do you do CTP? Do you have to do DWI at every center? Well, the answer to that is all politics are local, and it depends where you are. And so if you ask the guys in Stanford that question, because of the way their hub and stroke networks are set up, they want all their satellite hospitals, all their spoke hospitals to do CTP, because they don't want to have unnecessary transfers. If they get a patient transferred to thrombectomy, they want to know that patient really needs thrombectomy because they have a tiny ED and it's easy to get to, and they don't want to inappropriate utilize resources. It's just the opposite if you ask our friends in Los Angeles. In Los Angeles, the traffic is so bad that it could take an hour to transfer a patient from a hospital 2 miles away. So they want to transfer patients just with a non-contrast CT as quickly as possible. What about in Massachusetts? Well, in Massachusetts, we have about 72 primary stroke centers. What is a primary stroke center? It's a place that can do intravenous thrombectomy, can do CTA, but can't really do MR or advanced imaging, and cannot offer catheter thrombectomy. In Massachusetts, we only have about 8 centers that are comprehensive stroke centers that can do catheter thrombectomy, and 5 of those 8 are in the greater Boston region. And so we have this hub and spoke model where the 72 hospitals transfer it to one of the 8 hospitals to go along and do the thrombectomy. And so what we tell those hospitals is, at the referring hospital, get your CT to rule out a bleed, your non-contrast CT, get your CTA to identify if there's a large vessel occlusion, and that large vessel occlusion is a target for thrombectomy. And if you don't do thrombectomy on patients with large vessel occlusion, even up to 24 hours after stroke onset, those patients are going to decline. They're going to have late decay. They're going to do worse. And the patients who have bleed, no bleed on non-contrast CT, and have an LVO and are potential candidates for thrombectomy and transfer maybe only account for about 15 to 20% of all strokes. But that 15 to 20% are the sickest patients who are going to be those modified Rankin scores 5 and 6, who are going to die or be severely disabled, who are going to have a huge cost of care and have the biggest socioeconomic impact And those are the ones you want to treat. So those are the ones we should transfer. And then once you transfer them to one of those 8 hub hospitals that can do thrombectomy, then we'll figure out if they're eligible once they're transferred by doing diffusion or CTP for the core assessment. And how do you measure diffusion? You said it should be 50 to 70 mLs. How do you measure that on an image? Well, you take the hypodense or the restricted diffusion lesion and its length times width times height over 2. And that gives you a pretty good estimate, plus or minus 10%. So remember this formula: stroke volume is length times width times height over 2. A lot of this is done with AI now, and I don't want to run out of time, so I don't want to get into a lot of details on AI, but there's a lot of software out there that can help detect the large vessel occlusion, that could help analyze the perfusion data, that could even help see if there's a bleed. And a lot of this is work in progress. The one piece of work in progress I want to share with you is something that we are just submitted for publication. But basically, we have done a study where we've developed an AI based on the ground truth. We trained this artificial intelligence platform based on the ground truth of the diffusion imaging. And because we have 20 years of data where we got CT followed within 15 to 30 minutes by diffusion imaging on everyone, that's a unique data set. And what we trained the AI using that diffusion data set as the gold standard, as the ground truth, we actually got a better performance than radiologists. So this blue line is the ideal performance of diffusion in detecting stroke and calculating volume. And this blue line is almost identical to how the AI performed identifying the stroke on the non-contrast CT. And this dotted red line is how the experts like me with 30 years of experience were able to detect the stroke and estimate the volume. So we actually trained an AI that's better than a human. Because why? How could it possibly be better than a human? Because we didn't train it using humans. We trained it using the gold standard. And so it got almost as good as the gold standard, which means there are things that the human eye can't see on a non-contrast CT. It means that there's some subtle decreased density from the reduction in cerebral blood volume because blood has hematocrit effect and has a Hounsfield density. And that's even more apparent if you do it on dual energy, where you could distinguish that spectral different compounds. And there's probably different texture and different image noise in the region of the poor perfusion, even on the non-contrast CT, that the software algorithm was able to detect, but the human eye is not able to detect. So to me, this is very, very interesting, very, very promising and cool, and you'll be hearing more about this. But the goal of these software is mainly to help in patient triage from that hub to stroke model. And so I want to just, we have about 15 minutes left, and I want to leave some time for questions. So in the last 15 minutes, I want to just go over some practical points on how to look at the images, how to review a head and neck stroke CT and stroke CTA. What are some of those pearls and pitfalls? And so we already said, look at the head CT, look for a bleed. That's the absolute contraindication to IV TPA. And don't delay IV TPA by waiting to get the advanced imaging results acquired and analyzed first. You could do the acquisition for the CTA while you're mixing the TPA after you've already made that decision. Here's the other really important thing. One of the values of perfusion, which we already talked about, was that idea that it shows you a wedge-shaped distal deficit if there's a flow lesion. Why is that important? It's important because I think when the images are very thin slice and the source data and the axial images are coming up on the scanner, if there is a large vessel occlusion of the proximal middle cerebral artery, the M1 branch, or a T lesion where the internal carotid is occluded, then you're going to see that lack of filling. You're going to see that clot, even on the raw data. But once you get out to the distal M1, to the M2, to the MCA bifurcation, looking at the thin slice raw data as it's coming up at the scanner is very difficult. There are a lot of misses. And so how do we avoid those misses? CTP, we said, helps. But even if you're not doing CTP, the way we avoid those those pitfalls is to get thick slab maximum intensity projection. The techs could make those very quickly, semi-automatically, right at the scanner in under a minute. So give them some time to do that. What do those look like? They look like these thick, 3 centimeter thick slabs. And when you look at them, because it's a 3 centimeter thick slab, it really can lay out in the axial, sagittal, and coronal plane the entire vessel. The trick here, though, is not to make 1, 2, 3, 4, 5 3 centimeter thick images, because then bone is going to get in the way. You're not going to see what you need. So yes, you want the 3 centimeter thick images, but you want them filled at thin 5 millimeter images so you could scroll in and out of them. And so you're going to get a lot of those 3 centimeter thick images, but they're going to be separated by only 5 millimeters. And so you could scroll in and out in all 3 planes and see what you need to see. And you should look at those right away, because again, to make that transfer decision, all we want to know is there a large vessel occlusion? And we want to review the parenchymal images next for more subtle stroke findings where you could window and level and see gray-white differentiation. And here's a non-contrast CT. Here is a contrast CT. This is a paper we wrote a long time ago, but it still holds that when you look at the thick slab CTA source images, it's almost like a poor man's CTP, a poor man's perfusion scan, because you could window and level, and it helps you see those ischemic regions of low blood flow more sensitively than if you were just looking at the non-contrast CT. So you see here, there probably is a very subtle insular ribbon sign right here, but it's much easier to see that hypodense insular ribbon when you have the increased signal to noise by having given the contrast at the capillary level. And in fact, we do a much better sensitivity and specificity when we're looking for ischemia with the CTA source images versus the non-contrast CT. But to remember, it has the same limitation as perfusion, that we're looking at ischemia, we're not looking at irreversible infarct when we see that, and when the non-contrast CT is normal. And of course, you want to scroll up and down looking for extracranial occlusions all the way down to the left atrium to look for left atrial thrombus, because you want to find the source of an embolus if you see an embolus. And remember to always look at the thin slice source images in the head to rule out an aneurysm, and especially to rule out an aneurysm where there are vessel branches, where there are vessel bifurcations. That's where you want to rule out an aneurysm. So you want to rule out that aneurysm at the top of the basilar, at the ACOM A1, A2 junction, at the top of the ICA, where you have a T lesion, where the top of the internal carotid splits into the middle cerebral artery and the anterior cerebral artery. And one of the branches of the internal carotid artery intracranially, extracranially, the internal carotid artery has no branches. But extracranially, the mnemonic is SHOPA. It has 4 branches. Going from inferior to superior, the branches are suprahypophyseal, SH, O ophthalmic, P PCOM, A intercoroidal. And it's really only the PCOM and the ophthalmic that you see most of the time on these kind of things. So you want to make sure you look at that. And you also always want to have a checklist. So let's say we're transferring a patient by an ambulance from the spoke hospital to the hub hospital. And along the way, the patient is intubated and gets rushed into the CT scanner. The radiologists may be the only person to look to see where the trach tube is. And so we want to look at the scout image, and we want to look at the cross-sectional images that go into the mediastinum on the CTA from the arch to the vertex. And we want to see, is the right mainstem bronchus intubated? So you got to look for that. You have to have a checklist. If you don't look for it, no one else is going to look for it. And if they have a hard time hearing breath sounds in an ambulance, so you can't go by the physical exam. Here's another thing. We do a lot of CTAs for a lot of low yield indications. We do CTAs not only for rule out stroke or vertebral basilar disease, but we do CTAs for syncope, for dizziness, for mild headache, for mild trauma without any fractures. The rate of a positive CTA in those kind of indications is very, very low. And so when I see that a person over 80, an elderly person, is getting a CTA because they have dizziness or syncope, because they fell down, there's a very high chance the CTA is going to be normal. I'm not so worried about what the CTA shows. I'm much more worried that this is a person with osteoporosis and osteopenia and brittle bones, especially if it's an elderly female. And I'm much more worried that they had a fracture. So you can't get the whole stroke CTA and then forget to look at the coronal bones, because this was a type 3 dens fracture. And no one picked that up because they forgot to look at the bones. And so here's on the sagittal, displaced type 3 dens fracture. You could get spinal cord injury. You don't want to miss that. It's so easy to detect, but it just has to be on your checklist of things to look. And you want to make sure your technologists make these bone reconstruction of the whole neck in the sagittal and coronal plane, and that you look at them and you don't miss fractures on the cervical spine or skull base, and that you don't miss other things like wrong central line placement into an artery instead of a vein, pacemaker leads in the wrong place, or a right mainstem bronchus intubation. You don't want to miss this. And here's a good example of why we need coronal and sagittal views. Because if you just have a single view, you could completely misinterpret the images that you're looking at. And when you see things in two imaging planes, you could tell if it's really one middle finger or three fingers, which makes a big difference in interpreting what this guy is trying to say. So I'm not going to spend a lot of time on the specific clinical trials. We already said that all the trials used CT and CTA, but they all used a different way to measure core. And so some used a non-contrast CT to measure core, some used CTP or diffusion, some used collaterals. And it actually turned out, in terms of who benefited from treatment, you don't want to overtreat, but you don't want to undertreat. And using collaterals to measure core turned out to be the best balance between overtreating and undertreating. And remember the logical fallacy. The studies were designed to check if IAT works. They were not designed to determine what is the best way to measure core or what is the best way to select patients for thrombectomy. And so the jury is still out on that. So let me just show you an example. Here's a patient who had an abrupt onset of left hemiparesis, left-sided paralysis, and language loss, sudden onset in the hospital. And it actually turned out that this was an older woman who was visiting her husband, who was in the emergency room for chest pain. And he ruled out for MI, but she collapsed and had a stroke. And fortunately, she collapsed and had a stroke in the MGH emergency room. And when we look at this dense vessel here, you don't need a CTA to know there's a high probability that this is going to be a top of ICA, anterior cerebral artery A1, middle cerebral artery M1 occlusion. This is a T lesion with a T sign on the non-contrast CT with a hyperdense clot sign, hyperdense middle cerebral artery. But you know what? The non-contrast CT is stone cold normal. There is no vasogenic edema here. And when we get the CTA, it confirms that. We're not seeing the top of the internal carotid artery. We're seeing an occlusion in the proximal A1, ACA, anterior cerebral artery. We're not seeing the ICA here, and we're seeing an occlusion in the proximal M1, the proximal middle cerebral artery. But we're seeing more than that. When we look at the 6 lab CTA source images and window them to look at the gray-white differentiation, we see almost no perfusion, almost no contrast is reaching that part of the brain. So if this was a CTP study, it would look like there is no flow going to that CTP region. And basically, that in some places would be a contraindication to TPA and a contraindication to intraarterial thrombectomy. And so basically, because the non-contrast CT was completely normal, because she had the onset of the symptoms in the ED, and we knew exactly how long she was ischemic, and because there was a big flow deficit, in a way that was like the yellow light that said, you know, normal CT, but abnormal blood flow, try to treat quickly because maybe the infarct hasn't happened yet. And we were very confident of that. And we were able to get her on the interventional catheter thrombectomy table within about an hour of her stroke onset. And we found that clot and we opened it in the middle cerebral artery, and her follow-up scan showed almost complete normality. Just maybe a little teeny bit of residual restricted diffusion, some focal neuronal dropout at 90 days, a little bit of flare hyperintense signal, but certainly not a big stroke, not a big cavity. And so again, DWI, infarct likely despite immediate reperfusion, but blood flow changes, infarct likely without immediate reperfusion. I also could go into a lot of detail on the signal to noise ratio of CT perfusion and why diffusion is better for that, and how the error bars, when you're trying to compute the volume, we said we want a 50 to 70 ml cutoff for who's likely to have a good outcome and unlikely to have a good outcome. But when you do these Bland-Altman plots on the diffusion volume versus the CTP volume, you find out that the error bars for CTP, because the images are so noisy, are very big. And they could be up. I'm sorry, hello? Did someone have a question? Okay, I have about 5 minutes and I'm going to finish up. Basically, the error bars on the CTP is very big, up to plus or minus 60 mLs. And so if you're trying to measure a 70 ml cutoff, but the confidence interval, the 95% confidence interval in that measurement is plus or minus 60 mLs, when you're trying to measure 50 or 70 mLs, that's a very big error. And so it makes this much less reliable than diffusion. And in fact, when they did a meta-analysis of all those 2015 prospective clinical trials, comparing the trials which used CTP for core assessment versus MR for core assessment, what they actually found that the CTP was not as reliable as the MR in predicting who was likely to have a good outcome. And so basically, what is the take-home message? The take-home message is, if you're trying to make that decision about how big is the infarct exactly, and that piece of information is critical for you to decide whether to transfer a patient or whether to do a catheter thrombectomy and call in the stroke team, then you're going to get a more reliable measurement that is going to result in a better patient outcome if you are able to do diffusion, even up to 24 hours. And in fact, this is a picture of my friend Raul Nogueira, who was the one who trained here and then became the director of interventional neuro at Emory, and is the first author of the Dawn trial, which extended the time window out to 24 hours. He's actually now doing a trial called No CTP. Now that is nickname. It's not the goal of the trial, but there's a reason it's its nickname, and it's using non-contrast CT versus CTP to select patients for endovascular treatment, even in the very late 24-hour time window. And so basically that trial is really just started this past summer, and it probably got delayed because of COVID, but it's going to be very interesting. And especially if you put that trial together to the fact that we've now developed an AI, an artificial intelligence model that can very accurately detect stroke on a non-contrast CT, I look very much forward to seeing what this trial shows. So this is the answer to the question that, in part, is CT alone going to be enough to select patients? We won't know till this trial is done, but I think that potentially the answer is a provisional, hopeful maybe, a strong maybe. And just to finish up before we get to questions, this is stuff that we've even been thinking about. I said we've been thinking about it for a long time. We were even thinking about part of this in the late time window, going all the way back to PET scan studies that our group did back in 1989 with Bob Ackerman, where we looked at core and penumbra on PET scanning. And so I will end. I have about 2 minutes left if I want to leave 5 minutes for questions. I will end just saying a few final words about collaterals. And I think here is the biggest thing I would say. The biggest thing I would say is that pretty much all the information that you need to make the thrombectomy decision, you could get with collaterals, and it couldn't be easier, because all you really want to know to divide up patients into likely to benefit and equivocal or possibly unlikely to benefit is to break up their collaterals into symmetric versus in between, moderate, or poor, where poor is defined as a malignant collateral pattern. And CTA collaterals means on the CTA images, on those raw data thick slab images, it means you're looking out peripherally to see how good the flow is. And so this is an example over here of collaterals, because this is good collaterals. All of these vessels are filling. Actually, here it's very poor collaterals. None of those distal vessels are filling. So this is kind of an example of poor or malignant collaterals. And if even on the delayed CTA images, there is no contrast reaching the collaterals, that is called a malignant pattern, and it falls into that unlikely to benefit category. And so what we showed is that symmetric collaterals corresponds very nicely to small core, to DWI less than 50 mLs, whereas malignant collaterals correlates very well with DWI greater than 100 mLs. So just looking at the collaterals, you could break up patients into likely to benefit from recanalization, unlikely to benefit if it's a malignant pattern over more than half the brain, even on delayed images, or uncertain to benefit, which is kind of more that orange light, somewhere in between. But this is a good picture of a malignant collateral pattern where none of the distal branches, even on the delayed images, have contrast reaching them. And we actually did some pilot studies comparing that to CTP, and it was as good or better than CTP for making that transfer versus don't transfer decision, or the treat versus don't treat decision. And there's a lot of trials like that no CTP trial where we're trying to get more liberal with who we treat. Treat 24 hours if there's a CTA occlusion, even if it's a small core with a low NIH score, with a good clinical score, because they are likely to get worse if they have a large vessel occlusion. We've shown that this is cost effective in patients with acute minor stroke, it's still better and cheaper to do CTA on all these minor strokes than miss a single big stroke that's going to be a modified Rankin score 5 and 6, severe disability or death. That costs more to the healthcare system in dollars and in socioeconomic income and disability. And I think I'm going to end there. And there's a lot of other things we could talk about, like bridging therapy with IV TPA and late IV TPA, but let's not talk about that now. Let's just show our algorithm, which is how we now make our decisions. But when we want to measure core as accurately as possible, we do get the MR rather than the CT. And I'll stop there. It leaves us a few minutes for questions. I'm happy to stay on a few minutes longer as long as people want. And I guess what I'll start with is some of the questions that are in the chat. So just to go through those quickly, basically, let me scroll down them. And basically, do you perform CTA for patients with renal impairment? The answer is an unqualified yes, because the brain is more important than the kidneys, number one. So even when we didn't know about contrast use, we would do that. But number two, I don't know if it affected you, but we had a contrast shortage recently. And when we had this contrast shortage, we developed very low contrast dose CT protocols where we use dual energy, 80 kV iodine imaging, low kV dual energy imaging to have better iodine detection. And so we could do the CTA with less contrast, but get good or just as good signal to noise ratio. And then finally, I think that if you read anything by Matt Davenport that he's published in radiology, I think that the risk of renal impairment, even with low GFR less than 30, is overstated. And that risk probably, especially with post-contrast hydration and washing out the contrast, is probably lower than it's been estimated to be in the past. So that's the answer to that question. What is the standard protocol of a patient with penumbra and large core? Basically, we don't care about penumbra at all. We care about core. And I think that even in the Dawn trial, if you go back and read the Dawn trial, Raul Nogueira did not use an imaging penumbra. He used a clinical penumbra. So if his estimate was that it's a small core and there was a big clinical core mismatch, then he would treat up to 24 hours. If the patient had so it's based on the clinical. Right now, we will not do thrombectomy treatment if the patient's NIH stroke scale score is less than 6 or normal. But there are clinical trials underway to look at that. And again, one of the take-home messages here is that we're becoming more liberal with the criteria because the outcomes are still better in the treated group than in the untreated group, even accounting for the risk of hemorrhage. And so we do use the AI model to calculate stroke volume, but we don't, it's still research. It is not yet clinically approved. And is there a place for MR spectroscopy? My quick answer would be no. And the answer is no, mainly because it takes a lot of time, but doesn't add enough. And if anything, we try to do as little as possible. If we could prove that we could do just the non-contrast CT, we'd be happier with that. Because if it's faster and just as accurate, why not? But for now, the standard of care is doing at least a CTA. And if you're doing the CTA, you have to look at those collaterals. And all you have to do is look at symmetric versus malignant. And how do we define symmetric? It's very simple. If you look at the scan, and by looking at the scan, you can't tell which side the occlusion is on, then that's symmetric. And in fact, sometimes there's hyperemia. Sometimes it's actually asymmetric, but there's more flow in the ischemic hemisphere. What does that mean? It basically means that there's a great collateral flow, there's great penumbra, everything is maximally vasodilated, but it also means that there's sluggish venous outflow. It's like a flare cortical vein sign. And if there's sluggish venous outflow, it means that penumbra is going to collapse. So that falls even more in the category of, if you are going to treat and you see that hyperemic penumbra, treat fast, because it means that tissue has poor sluggish outflow and is going to fail very soon. Okay, so that's what collateral is. And again, we don't yet have, it's still research, there's not yet approval. But we're going to try to get that very soon, and more to follow. We will be talking about that. And whether we do the diffusion depends very much on the situation. As you can see from this flow chart, we don't routinely do it, but if the patient was excluded because of too big a core on the perfusion, then we'll do it to make sure we're not unnecessarily excluding patients from treatment. Because it's almost worse to deny treatment to someone who'd benefit than to give treatment for someone who might have a hemorrhage. Because we know, not yet from clinical trials, but from pilot data, we know that even the ones who hemorrhage still seem to have a better outcome with treatment than without. So this is all work in progress. That is not the current standard of care. And watershed is a whole different category. We're talking here about thrombectomy up to 24 hours for large vessel occlusive stroke. And again, SPECT is going to take too long. CADASIL is a whole different thing, way beyond the scope. We're a little over, but I'm happy to take some verbal questions if they are, if there's anything really important. And otherwise, what you guys can do is you could email basically Ahmed and the organizers, and they could forward those emails to me, and I'll be happy to answer your questions. So I'm going to stop there, Ahmed.
And thank you very much, Dr. Lev, for this very informative session. And it's definitely very impactful to know the correct diagnostic approach to stroke. So thank you very much for sharing your knowledge. And we would really appreciate if we have you with us for further education and sessions.
My pleasure, absolutely. And I'll say two things in closing. One is I've been to Cairo and I love Cairo. So I'm hoping at some point when it may be 10 years from now, but what I usually do is take what's called a busman's holiday. Whenever I take a vacation in a given city, if there's people I know there, I'll go and give a little lecture or a grand round. So if I'm ever in Cairo, I will be happy to give you guys a call and come by and say hi, and maybe there'll be new information then that we can share.
It'll be our pleasure, of course.
That's number one. And number two is that, you know, I think that we have, and I wasn't able to put this into the slides, but one of the things we do here is that if you guys ever come and visit Boston, please stop by Mass General and say hello. And one of the big historic things we have in Mass General is what's called the Ether Dome. And it's the medical amphitheater where we first did, I'm trying to see if I have it as a virtual background, and unfortunately I don't, but it's the medical amphitheater where we did the very first anesthesia in the world. And it was a patient who had a jaw tumor, and up until then there was no anesthesia, and he got a little ether, which is why we call it the Ether Dome, and he didn't feel pain and he was unconscious, and they took out the tumor and it was changed the world. And one of the things we have in Ether Dome is a gift that is a mummy. And I don't remember exactly which mummy it is or who it is, but one of the things we've done is we've been working with the Museum of Fine Arts in Boston that has a good Egyptian collection, not nearly as good as in Cairo, but we've been working with them, and we've done a lot of CT scans of these mummies, and we've done them dual energy. And Raj Gupta, whose picture I showed at the beginning, the chief of neuroradiology, is actually a consultant He's actually a former CT engineer who built CT scanners, and he is a consultant for the Museum of Fine Arts. And he's gone through their mummies, and we know exactly what they died of. And it turns out most of them have died of tuberculosis. And we could actually see that. And so lots of interesting stuff here if you guys are ever visiting Boston. Anyway, I'll stop there, but thank you again for inviting me. This has been a lot of fun.
Yeah, thank you very much, and we look forward to having you again.
All right.
Thank you.
Be well.
Thank you very
Thank
much,
you.
Doctor. Thank you very much, Dr. Lev. Dr. Lev, can you accept our we will appreciate your coming to visit Egypt
That,
next June, inshallah, in our conference.
we'll figure it out at some point, but again, I thank you, and this has been terrific. So thank you.
Thank you. Good evening.
All right.
Okay, thank you very much. Thank you.
Bye-bye.
Thank you.
All right, so I'd like to thank you all again for your attendance, and I'd like to thank Dr. Hisham for arranging today's session. And it's my great pleasure and honor to present Dr. Kowal. Dr. Kowal, are you with us right now?
Yes, can you hear me okay?
Yeah, we can hear you.
Great.
Can you please share your screen, please?
Yes, let me,
Just to make sure it's sharing. Okay, great.
is that sharing okay?
Yeah, it's okay. Thank you very much. It's my great pleasure and honor to present Dr. Daniel Kowal. Dr. Kowal is an associate professor at UMass Chan Medical School, Bay State. He also serves as the chief and the medical director of the ultrasound based at Bay State Medical Center. And Dr. Kowal did his fellowship in abdominal imaging at Mass General Hospital and Harvard Medical School. And he is the founder of Radiology Headquarters YouTube channel and podcast, which has a lot of educational material in radiology. And Dr. Kowal will be presenting today about the imaging of ovarian neoplasm. So it's a great pleasure having you with us today, Dr. Kowal.
Hey, thank you for that intro. It's a delight to be here. So I'll get going. So I'm going to talk about imaging of ovarian neoplasms. So there are three main categories of epithelial tumors, of ovarian tumors: the epithelial subtypes, the germ cell tumors, and then sex cord stromal tumors, as well as metastatic disease. But in the interest of time, I'm going to focus on just the major ovarian tumors that also have imaging features that can be differentiated. So I'll try to guide you through the appropriate differential when narrowing down an ovarian mass. So why don't we start with epithelial tumors, since that's the most common subtype. So there are five main subtypes. There's the serous, the mucinous, the endometrioid, and then clear cell and Brenner tumors. So there's a few general things we can say about epithelial ovarian tumors. They tend to be cystic. When they're malignant, they have varying degrees of solid components. And the prevalence increases with age, peaks at about the 6th to 7th decades of life. And most of these tumors are benign, about 60% of epithelial tumors. And they tend to be unilocular when they're benign. Like this one, this is a T2 weighted image showing a simple cystic ovarian neoplasm epithelial. They often have a thin wall or thin septations that are less than 3 millimeters in thickness. So here's a CT scan. You can see that there is a septation, but it's rather thin. And the walls are also quite thin. And also on ultrasound, this mass is primarily unilocular, but there is some mild thin septation with no mural nodularity or abnormal vascularity. And this was a seromucinous cystadenoma on pathology. Now, when these tumors are malignant, which is about 40% or borderline, they classically will have a papillary projection. And that's a distinctive feature of malignant epithelial tumors. And we have that here, this kind of this mural nodule or papillary projection. The wall will be thick and irregular with septations. Here we have this multilocular cystic mass with these irregular thick septations. You might see a large soft tissue mass with some areas of necrosis, as in this case. And we start to see peritoneal implants, pelvic wall invasion, and adenopathy with the malignant tumors. So here we have this thick peritoneal carcinomatosis in the omentum. And ascites also is a sign of malignant epithelial tumors. So using the 2018, the most recent American College of Radiology appropriateness criteria to image an adnexal mass, which is indeterminate, in a patient that has no acute symptoms. The initial follow-up is considered ultrasound pelvis. That's usually appropriate, as ultrasound provides excellent resolution, and the specificity of transvaginal sonography for diagnosing ovarian cancer is up to 97%. And then MRI pelvis without and with contrast when it's available is also appropriate because of its superior soft tissue characterization, particularly compared to CT, and lack of radiation. And it's also helpful for problem solving if you're having trouble determining the origin of the mass, particularly if it's uterine or ovarian, and I'll show you a case of that a little later. So just an example of the utility of ultrasound over CT. Here's a large pelvic mass here on CT. It looks like it's primarily cystic, but on ultrasound, we can see that there is actually a papillary projection a bit more conspicuously than on CT because of that improved resolution. So let's look at a few subtypes. So we'll start with this one. This was a 21-year-old patient who presented with abdominal pain, and this adnexal mass was detected. There's a bit of quantum model artifact because it's a larger patient, but on ultrasound, we see that it's unilocular and cystic and rather large. And this turned out to be a serous cystadenoma. So this is, this is the most common benign epithelial neoplasm. They're usually thin-walled, unilocular, and simple in appearance, and they can even mimic a physiologic cyst, particularly when they're small. And just to show you on different modalities, here's a MRI. There's a left adnexal mass here on T1 weighted images. There it is on T2. You can see that it's iso-intense to the urinary bladder, and it's homogeneous and simple. There's the uterus there with part of the fallopian tube draping over the mass. And then on post-contrast images, we see that there's no internal enhancement. It's simple, unilocular. There's a thin wall of enhancement, but no mural nodularity or any suspicious features. This patient actually had a PET CT for different reasons, and just to show you that there was no avidity in that area. So a typical benign serous cystadenoma. And another feature that can help you identify these tumors is they are more commonly bilateral than some of the other ovarian tumor subtypes. So this patient has a simple ovarian cystadenoma on the right. It does have a single thin septation, and then also one on the left as well. So I mentioned these can be confused with regular cysts. So how do you follow up simple cysts? Well, in my practice, we often use the Society of Radiologists and Ultrasound guidelines, the 2019 guidelines. And that states for a premenopausal patient, a simple cyst really doesn't need follow-up unless it reaches 5 to 7 centimeters. Postmenopausal patients, we lower the threshold a bit. So if the cyst is more than 3 to 5 centimeters, and we'll tend to use that higher threshold if we exceptionally well visualize the cyst, meaning if we get a great look at the cystic mass and there's no bowel gas and the patient's body habitus is conducive, then we'll use the higher threshold for follow-up. And that follow-up interval is 6 to 12 months. If there's any uncertainty as to whether the cyst is simple or not, like if you're wondering if there's a few scattered echoes or if there's some question of mild complexity, you could do a follow-up sooner in 2 to 6 months. And then at that point, we'll tend to follow these until 2 years. If they're stable, we'll presume it's a non-neoplastic or an indolent benign neoplasm that doesn't need any further imaging. But even if it's increasing, as long as the morphology hasn't changed, we'll assume it's a benign neoplasm like a serous cystadenoma, and then that can be managed clinically with imaging if needed. Now, if you have a case like this, which is not a simple cyst, we would not use that criteria. Or if the simple cyst on follow-up developed this morphology, this is much more concerning. So we have a cystic mass here that looks simple, but then we have this area of mural nodularity, this papillary projection. And that could be clot or debris. So you always want to add color or power Doppler imaging to that. And we do see that there's some flow in it. And it's a good idea to confirm that there's true flow and this isn't just flash or twinkle artifact. And we do have a waveform here. So this is a mural nodule, a papillary projection. And here's a close-up of that papillary projection showing how frond-like and solid it is within the cystic mass. In this case was a serous cystadenocarcinoma. So this, just like serous cystadenoma is the most common benign epithelial ovarian neoplasm, this is the most common ovarian malignancy. And classically, it will be a cystic mass with this papillary projection. And also, clinically, these will usually have an elevated CA-125 level in more than 90%. So that's another clue if you have an ovarian mass and the biochemical data available, that can help you. Now, there's another interesting presentation for this particular tumor. And that's something that we can see on ultrasound, but is often more conspicuous on CT when we're evaluating for staging. And you can see here the CT of the pelvis with oral and intravenous contrast. There's this lobular multilocular mass here. And it looks like there's some areas of calcifications. It's difficult to differentiate those since we also have oral contrast on board. So if you manipulate the windows on the CT to closer to bone windows, you can more clearly see that this mass has some calcification within it. And it's separate from the oral contrast. And here we can see even better that this is all irregular calcification, and see how it's a little less dense and looks a bit more chalky compared to the oral contrast in the bowel. And this is another case of serous adenocarcinoma with pseumomatous calcifications, and that's seen on CT in about 12% of tumors. And the relevant point for the radiologist is that these metastatic implants may calcify, and it can be quite subtle. So this is the same patient. Do you see where the metastatic calcification is? This is just the appendix as a clue. But yeah, there's this irregular calcification there in the rectus abdominis muscle, and that's actually a metastatic focus. So let me just show you a different case. This was another patient with serous adenocarcinoma. It's actually the low-grade type that tends to have this calcification. And we see similarly a multilocular mixed cystic and solid mass in the pelvis with these areas of irregular calcification. And you see the metastatic disease on the abdomen here. Well, we have some subcapsular metastatic disease there, this punctate calcific omentocarcinomatosis. And then we also have some mesenteric calcified implants as well. So it can be very subtle. And this is a little scary here. You might just dismiss this as a bowel loop, right? Because it has oral contrast in it compared to these other loops. But when you window it closer to bone window, it again has that chalky appearance compared to the barium in the bowel nearby. And then it's very helpful to look at reformatted images. And this is that area we were looking at. That's clearly not in a bowel loop. And this is all just metastatic calcification there spreading out. And we also have some posteriorly in the cul-de-sac. And this can be pretty confusing. At an outside institution, this particular patient, this was called ruptured colon with barium. The patient had a barium enema, and they thought this was residual barium, but it's actually all metastatic calcification. So the teaching point there is use reformats, and bone windows can be very helpful because the oral contrast can be confusing. And then I'll just make one more point about that, the oral contrast issue. This is a different patient with pelvic CT. There's no IV contrast, but we have oral contrast, and it's difficult to identify this, but these are calcified implants here, and this is all oral contrast. And you can see a bit more, obviously, when we look at the rest of the abdomen, that there's diffuse multifocal osseous calcific metastases within the liver, spleen, peritoneum. But often if I'm able to protocol these CT scans beforehand, if I know the patient has serous adenocarcinoma and they're staging, I'll try to avoid giving oral contrast because it doesn't really add anything. It can actually reduce your sensitivity for detecting metastatic disease. So this is a different pattern of metastatic disease here. Different patient. We have not something calcified, but we have the soft tissue confluence in the omentum. And this patient actually had a large bowel obstruction. You can see the colon is dilated. And as we move inferiorly, that's due to this mixed cystic and solid mass in the pelvis. And that was another serous adenocarcinoma. And if we look at that on real time, you can see the omentocarcinomatosis there in the dilated colon leading into that mixed cystic and solid mass. So these tend to metastasize. If they're not calcified, it'll be this thick confluent soft tissue that we will, sometimes refer to as omental cake, but you might also see this infiltrative pattern of omental carcinomatosis here. And this can be confusing sometimes, particularly in cirrhotic patients or other patients with ascites. You'll see a bit of infiltration in the omentum, but you shouldn't see this type of expansile enlargement of the omentum. That tells you that you're definitely dealing with soft tissue here. And this is all omental carcinomatosis with some ascites as well, malignant ascites. All right, let's move on to a different tumor. So this was a 46-year-old female presenting with the CT scan showing this what looks like a unilocular simple cyst, right? So you might think it's another serous cystadenoma. But when we look at the rest of the abdomen, you can see that there are these multilocular septations here, and it's definitely not as simple as the cases we've been looking at. And here it is on the coronal image. It's right in the midline, and it has these multilocular appearance with these fairly thin septations. And this turned out to be a mucinous cystadenoma. So mucinous tumors compared to serous tumors are less common, but they're almost always multilocular, and they're often quite large at presentation. They're larger usually than serous tumors, and they can be huge, like enormous. And here's another example of that. So do you notice anything on this scout view for the CT scan? This is one of those cases where what's not there is the clue. We see there's bowel gas up here in the abdomen, but then there's this void here telling you that there's a large mass. And indeed, on the CT, you can see that there's a huge multilocular cystic mass here with innumerable little septations, and many of these are thickened. And we also have some ascites. And here's the coronal view showing that there's ascites there. And on real time, you get a good sense of how multilocular this mass is. And also that there is some heterogeneity to the cystic component. Sorry, we're stuck. And this was a mucinous cystadenocarcinoma. So these are often quite large, and they may have solid components, just like any malignant epithelial ovarian tumor, and often thick septations. The unique feature of these tumors is they often will have a proteinaceous, hemorrhagic, or mucinous components in these locules, so that will give you a somewhat heterogeneous appearance on CT or ultrasound. So on ultrasound, we'll classically see scattered low-level echoes, and on CT, you'll have this variable density, and also on MRI, variable signal intensity. And when these rupture, they can cause a phenomenon known as pseudomyxoma peritonei. But let's look at an MRI first, just to highlight that the differing appearance of the mucin and all the different locules. So here we have T1 and T1 fat suppressed images, and you can see this is the mass here. It's multilocular. It has some simple areas that probably have more simple fluid, like this T1 hypointense area. But then we also have these brighter areas that are T1 hyperintense, and then areas in between that have kind of a mixed signal intensity. And so that's why this appearance is sometimes referred to as a stained glass appearance, because you have varying degrees of mucin and fluid. And here it is on T2 sagittal. The tumor is quite large. Here's the uterus getting compressed there, along with the urinary bladder, and then there's the urethra. And on post-contrast gadolinium images, you do see that there are some areas of solid enhancement, which tells you that this is definitely a malignant tumor. And because it's large and multilocular and has this stained glass appearance, you would be thinking mucinous cystadenocarcinoma, which that's what this turned out to be at pathology. And as I mentioned, when these rupture, they can cause this pseudomyxoma peritonei appearance. And that will give you these scalloped hypodense masses that kind of track along the edge of the liver and indent it. And you also have other areas of loculated ascites. And this is how it would look on ultrasound. This is the same patient showing one of those implants scalloping the liver. And there's that complex malignant ascites that's also multiloculated. And notice all these scattered low-level echoes throughout the ascites telling you that there's mucin. So this is when you have these metastatic implants of mucinous tumor that spread along the peritoneal surface. And that mass effect and scalloping on the liver is quite suggestive. The only other things that you might see that occur with are like hepatic or perihepatic abscesses can sometimes scallop, but that will have a very different clinical history. And although this is an ovarian neoplasm lecture, these actually more commonly occur from the appendix when you have a mucinous tumor that ruptures. And it can often be difficult to determine the site of origin if the patient presents with really advanced pseudomyxoma peritonei, because there's just these cystic globules everywhere. It might be hard to identify the primary tumor. All right, so just to summarize how to differentiate serous and mucinous tumors. So serous tumors are more common than mucinous. Serous tumors are unilocular, but mucinous tumors tend to be multilocular. Serous tumors are usually smaller than mucinous tumors, which can be massive. And serous tumors are more likely malignant, about 40%, compared to only about 20% of mucinous. Serous tumors might be bilateral, but that's uncommon for mucinous tumors. And you might see this calcification, the pseumomatous calcification with serous tumors. but it's unlikely with mucinous. And if you do, the calcifications tend to be linear. When serous metastasizes, you might see peritoneal carcinomatosis, but pseudomyxoma peritonei will occur when mucinous tumor ruptures. So you can see I gave you a little learning mnemonic there. You can remember mucinous tumors start with M, so they also tend to be multilocular, massive, and pseudomyxoma peritonei when they rupture. Now, this tumor looks similar to what we've been looking at. It's kind of large and cystic, and but it only has a minor peripheral cystic component with septations at the margin with some mild thickening. And you can see that there. And this turned out to be a borderline epithelial tumor. And this was actually more specifically a borderline mucinous tumor. So these are epithelial tumors of low malignant potential. When I first heard this term as a resident, I assumed it was like saying, oh, there's borderline cardiomegaly or borderline splenomegaly. But this is actually a specific histologic subtype of a borderline tumor, and it's either serous or mucinous. And they're usually in younger patients, and they have a better prognosis than ovarian carcinoma, which is important because there's the potential for ovarian or uterine-sparing surgery compared to ovarian carcinoma. Here's a different case showing a cystic mass with these papillary projections. And so we know that it's a serous, we know that it's an epithelial ovarian tumor, and we have some flow in that papillary projection. And it turned out to be a borderline serous tumor. So these are difficult to diagnose preoperatively because they don't really have clearly benign imaging features, and this particular case could have just been a serous cystadenocarcinoma. But you can suggest it if it's a younger patient, or if the CA-125 levels are only slightly elevated or normal. Because remember, most serous cystadenocarcinomas will have an elevated CA-125. But again, it's tough to diagnose these preoperatively. And these can also overlap in appearance with a benign mass that's not a neoplasm, but I thought it would be worth discussing in this lecture because there is some overlap. So here we have a nice mass that's kind of bilobed, and it's got homogeneous low-level echoes with a ground glass appearance. We don't see any internal vascularity. Here's another example, a different patient, these homogeneous low-level echoes. These are endometriomas. So endometriosis, just some brief vocabulary, are ectopic endometrial glands and stroma outside of the uterine cavity. Endometrioma, more specifically, is when you have an endometriotic cyst in the ovary. And then endometriosis will also include extraovarian implants as well as adhesion. So that's all part of the endometriosis spectrum. So in ultrasound, these endometriomas will classically have homogeneous low-level internal echoes. So that's different from the scattered low-level echoes that you'll see with mucinous tumors, which also tend to be more complex. But again, there is some overlap. And sometimes these can have peripheral punctate echogenic foci, like in this case, but you shouldn't really see any internal vascular flow in there. You might see some twinkle artifact, but not an actual waveform, because there shouldn't be solid mural nodularity. They can, though, be multilocular and bilateral. So just to compare, so this was a patient presenting with a 9-centimeter mass, and the question was endometrioma. Well, it looks like it has homogeneous low-level echoes. We don't see any internal flow. There's a little peripheral septation here, and then a little punctate echogenic nodule. So this could be an endometrioma, but it ended up being a borderline mucinous tumor. And just to show you how this can really be difficult to differentiate from endometrioma. So these are patients of similar age, 23 over here and 21 over here, both with large tumors, 14 and 16 centimeters, and with these homogeneous low-level echoes. So one is a mucinous borderline tumor, and the other one is an endometrioma. So which one do you think is which? Yeah, it's pretty difficult, isn't it? So this ended up being a borderline mucinous tumor, and it actually had intraepithelial carcinoma and microinvasion, but this was an endometrioma. So these cases can be quite challenging, and that's why MRI is really a great tool for specifically characterizing endometrioma. And it's actually the most specific imaging modality for this diagnosis. Tagashi did a great study back in the early 90s, actually, that showed this appearance is 98% specific for endometrioma. And that's when you have this homogeneous T1 bright lesion that's uniformly light bulb bright. And then also is T2 dark, a phenomenon we often describe as T2 shading. And you can see it's here. And you might also have a T2 dark spot that kind of adds specificity. And it has this appearance because unlike a hemorrhagic cyst, which will be brief and only last for like 6 to 8 weeks, this stays around chronically. So you'll have hemorrhage of varying ages
معرفش
and
ايه الموضوع.
viscosity, and that will give you this appearance. And as I was saying, these can be bilateral. Here we have homogeneous low-level echo masses bilaterally, but on MRI, they're homogeneously T1 light bulb bright, and then they're T2 dark. So that's very specific for endometriomas. And again, mucinous tumors don't tend to be bilateral, so that's another clue that you're dealing with endometriomas. Now, one thing to keep in mind with endometrioma, about 2.5% can have malignant degeneration. So it's not common, but it's something we look for. And you can see this is a case, we have this multilocular endometrioma here. It's T1 bright, and it has some areas of T2 darkness. And what we look for are enhancing mural nodules. That's the most specific finding for malignant transformation. So here we give in contrast, and we can see the uterus is enhancing normally, but then it's hard to tell, is this really enhancing because it was intrinsically bright to begin with, right? So when you give contrast, it's hard to see if something's getting brighter. So it's very helpful to use subtraction imaging where we'll subtract the post-contrast and the pre-contrast series. And so what you're left with is only true enhancement. So the uterus is enhancing, and we see the septations of this multilocular endometrioma enhancing, but no mural nodularity. And this turned out to be just a benign endometrioma. But what about this case? So this kind of looks like an endometrioma here, right? On ultrasound, it's homogeneous low-level echoes, but we're seeing all this convex mural nodularity. You could sometimes have peripheral clot, but it shouldn't have this mass-like configuration. And then on CT, we see some multilocularity and in areas of enhancement. And this is patient on pathology turned out to have endometrioid carcinoma with underlying endometriosis. And this is a different patient with the same diagnosis, also with underlying endometriosis, this kind of multilocular cystic mass with these areas of solid mural nodularity. So this is endometrioid carcinoma. So this is the second most common malignant epithelial tumor. And what's the most common? Yes, the ovarian cystadenocarcinoma. And this is the most common malignant tumor to arise in the setting of endometriosis. And it tends to have a large complex cystic appearance with solid components, but it can be kind of nonspecific. But if you have a history of endometriosis, that's helpful. And there's another feature as well that can clue you into this diagnosis. So this is a different patient with a nonspecific multilocular cystic mass here. But when we evaluate the uterus, there's irregular heterogeneous endometrial stripe thickening. And there's confirmed with spectral Doppler imaging that there is indeed flow. And here's the CT for the patient done for staging. And you see this irregular thickening of the endometrium. And with endometrioid carcinoma, you can have synchronous endometrial hyperplasia or carcinoma in up to about a third of patients. And this patient was found to have synchronous endometrial carcinoma. And then here's the right ovarian endometrioid carcinoma on pathology. So that can help you if you have a multilocular cystic mass in a patient with a history of endometriosis, and you also have endometrial thickening. Another clue is sometimes endometrioid carcinoma can be bilateral in up to 50%. So similar to serous cystadenomas and cystadenocarcinomas. Now, this was a different patient also with a history of endometriosis, and we have this cystic mass here with areas of mural nodularity. So right away, you should be thinking, okay, this looks like a malignant epithelial ovarian tumor. I don't know what subtype it is, but it's most likely that. And then we want to confirm that again with color Doppler and spectral Doppler to show that there's true flow. And this isn't just proteinaceous debris or hemorrhage. And we do have a definite mural nodule, and that's also seen on this CT with this mural nodularity, these papillary projections. So this appearance is nonspecific, other than saying it's an epithelial ovarian tumor, but this turned out to be clear cell carcinoma. And after endometrioid carcinoma, this is the second most common malignant neoplasm to arise in the setting of endometriosis. And this patient did have an underlying endometrioma. And it often mimics a borderline serous tumor or a serous cystoadenocarcinoma. And those are more common than this tumor. So if I was reading this prospectively, I would put those as my first differential. But clear cell is the second most common tumor that can arise in the setting of endometriosis. And then to finish with the last epithelial ovarian tumor subtype, this one's a little different than the others. Here we have a solid tumor and it's small, and you can also see that there are some amorphous calcifications within it. And this is a Brenner tumor. So these aren't too common, but they're usually benign. And they tend to be small. That's something that's a differentiating feature, less than 2 centimeters in size. And this amorphous calcification is characteristic. They usually only mild to moderately enhance, and they're usually solid, but they might have cystic components. And that solid component, like most fibrous tissue, will be T2 hypointense on MRI. And another clue that you might be dealing with a Brenner tumor is if you have additional tumors. So if there's like a contralateral ovarian mass, and you have this solid small mass with calcification, that suggests Brenner tumor. The other main thing in your differential for this type of tumor, though, would be a fibroma, ovarian fibroma, which I'll talk about in a little bit. All right, I'll move on to the second category here now. This is dermoid cysts for germ cell tumors, and this is by far the most common in this category. So here we have T1 and T2 MRI images, and you can see that the fat is hyperintense, and we have this left ovarian mass here. And then, so just that by itself could be fat, but you want to add fat suppression because hemorrhage could also be T1 and T2 bright, depending on the stage of the blood. And you can see that it becomes hypointense, even darker than the subcutaneous fat. So that's extremely specific for the presence of intratumoral fat. And this is typical for a dermoid cyst. So these are also known as a mature cystic teratoma. And this is the most common ovarian neoplasm. It's benign, and the mean age that we see it is around 30. So this hallmark is establishing the intratumoral macroscopic fat, as opposed to the microscopic or intravoxel fat that we'll tend to see in adrenal adenomas and hepatic steatosis. This is the fat that looks and behaves similar to fat in the subcutaneous tissues and then the intra-abdominal fat. So the signal will be nulled with just routine fat suppression. And the specificity of MRI in this diagnosis is quite high. It's up to 99%. It's not 100 though. You never want to trust anything that claims to be 100% specific. Here is a CT example showing how heterogeneous and complex these can look. It's because they arise from mature tissue from 2 or more embryonic germ cell layers. So sebaceous material, hair follicles, skin derivatives, fat, muscle, bone, and other tissues lined by squamous epithelium. So that's why they'll have this very heterogeneous appearance. And they tend to be, they can be bilateral in about 10%. This was a different patient with bilateral. So CT is also quite specific for this diagnosis, which it's one of the few diagnoses of ovarian neoplasm that CT can be specific for the subtype. And because we see that macroscopic fat, which will be isodense to the subcutaneous fat and have a density of usually less than negative 30 Hounsfield units. Now, what about ultrasound? Since that's usually the first line evaluation, well, the specificity is quite high. It's almost 100%. And the most common appearance is this cystic mass with a densely echogenic shadowing component known as a Rokitansky nodule. And that appearance is has the single highest positive predictive value of any feature of a dermoid cyst. Sometimes it's also called a dermoid plug. And that's often where the teeth occur or the hair grows out of this dermoid plug. It's also referred to as the tip of the iceberg sign, particularly when it's large, because it will shadow out the rest of the dermoid cyst. And it's usually rounded, as in this case. And again, this is the most common appearance for a dermoid cyst on ultrasound. There's another key feature that we often see, and you can best appreciate it on real-time imaging. And here you can see these dot dash appearance, which are little hyperechoic lines and dots extending through the ovarian mass. And that's very specific for a dermoid as well. That's this dot dash pattern, or known as a dermoid mesh. And it's often actually caused by hair that's coiled in the cyst cavity. And you often will get this kind of hypoechoic appearance throughout the dermoid cyst because the sebum within it might be hypoechoic or anechoic. It depends on the temperature and the composition of the sebum. Here's a different dermoid cyst collection here, just showing some of the other features. This one has these hyperechoic lines and dots. You can also get fat fluid levels where you have this echogenic fat layering along this anechoic region. And then we also get these regional diffuse bright echoes here. And then on CT, you can actually see that fat fluid level quite nicely. And there's also a calcification there resembling a tooth. And sometimes dermoid cysts, oh yes, these fat fluid levels, I should mention the sebum or the sebaceous material is actually liquid at body temperature and it's different in room air. So you might see some differences there in the real-time path versus what's happening inside the body. And this floating hyperechoic liquid fat is typical along with these diffuse or regional bright echoes. And sometimes you might only have these diffuse bright echoes, and this is difficult to differentiate from bowel gas sometimes, right? But you do see there's the ovary is here and you have a bit of a claw sign cluing you in that this is arising from the ovary. And here we confirm that on MRI. This is T1 hyperintense, isointensity adjacent fat, and then it suppresses on the T1 fat suppressed, the signal is null. And then a very specific but quite rare feature is this one. Here we have a large dermoid cyst. We do have this kind of echogenic shadowing component that's like a Rokitansky nodule. We also have some areas of dot dash, but then look at this. It's like a pile of small little marbles here, like a sack of marbles. These are floating echogenic spherical structures. So this is uncommon. It's rarely seen, but if you do see this, it's pathognomonic for a dermoid cyst. And we can have a similar appearance to this when you have a dermoid cyst in the floor of the mouth. That's that sack of marble sign. So it's rarely seen, but when you do see it, it's extremely diagnostic. Now, just to discuss a few pitfalls for dermoid cysts, I alluded to this a minute ago, but particularly when you have really large dermoid cysts, they can be overlooked and it may appear as though that this is just bowel gas shadowing out the ovary, but this was actually a very large right dermoid cyst. So just be careful. And because obviously these won't peristalse at all, unlike bowel. Here's a different mass. This one is very large. And you might wonder, is this an endometrioma? It's got low-level echoes, or could it even be a mucinous tumor? Because these are kind of scattered echoes. And then we notice at the inferior margin of this mass, we have this area of multilocularity with these thick septations. It looks complex. And then on the CT that this patient also had, this is the more superior aspect of the mass. You can see it's very nonspecific. It just has this non-simple fluid density material within it. But then more inferiorly, we have this little Rokitansky nodule. We have some macroscopic fat here with a calcification. This is actually corresponding to this area. So sometimes when you have a fluid predominant dermoid, it can deceptively mimic an endometrioma or a mucinous tumor because the fluid, all that sebum will look kind of like an endometrioma or mucinous material. So search for that Rokitansky nodule or some area of fat. So in addition to pitfalls, there are certain complications that can surround dermoid cysts. This is a different patient. We have this mixed solid and cystic mass with some scattered low-level echoes there and septations, echogenic material. And then what do you think is happening here? This is the adnexa. Notice that there's this swirling tubular pattern there right here. And then we have this tube that looks engorged and twisted. And at surgery, the left fallopian tube was actually torsed 4 to 5 times around itself, and it was purple and blue. When they detorsed it, though, it turned back immediately to a pink, healthy color. So the most common complication for dermoid cyst is torsion, and that can occur in up to 16% of dermoids. And just in general, ovarian enlargement is the greatest risk factor for torsion, usually due to cyst or neoplasm, which in dermoid cyst is the most common. And then rare complications would be rupture, which can cause a granulomatous peritonitis. So here we have some fluid leaking out. And this patient had presented to the ER with sharp abdominal pain. And you can see there's actually some fat here leaking out of the dermoid because it was partially rupturing. These can also rarely have superimposed infection and appear with an abscess. Malignant transformation is also possible in 1 to 2% of patients, usually post-menopausal, and will degenerate into squamous cell carcinoma. And then rarely these can also have hormone secretion. So with struma ovari, when you have thyroid tissue associated with it, it can cause hyperthyroidism. They can sometimes produce testosterone and cause virilization and even carcinoid syndrome, but that's quite uncommon. And then very rarely, it can cause an anti-NMDA receptor encephalitis, which is quite uncommon, but has been made more popular after a previous episode of Grey's Anatomy that featured this diagnosis. And here's an example of a malignant teratoma that was actually rupturing and it had squamous cell degeneration. So the malignant tumors will often have less fat and more soft tissue. You can see the fat here, and the margins are somewhat irregular. And then you can see these globules of fat here corresponding to fat outside of the tumor since it's ruptured. All right, now I'll talk about the last category of ovarian tumors, the sex-scored stromal tumors. And just a note about these tumors, most of these tumors are benign or confined to the ovary at the time of diagnosis, but there are malignant versions as well. So here's a patient presenting on ultrasound, 39-year-old female, and had this mass that looks like a fibroid. So it was questioned whether is this a ovarian mass or a pedunculated exophytic fibroid. And you can see there is the ovary here with a claw sign. So that's a clue that we're dealing with an ovarian mass. This patient did go on to MRI, and on these T2 weighted images, you can see this lobular T2 hypointense mass there in the right adnexa. Here's the uterus here on these axial images. And then notice that there's the ovary, and we do see a little claw sign, a claw of ovarian tissue around this mass, telling you that's where it's arising from. And here it is on the sagittal T2 weighted image. There's the urinary bladder there. So here we've kind of confirmed it's arising from the uterus and not a fibroid. I'm sorry, it's separate from the uterus, so not a fibroid. So these are benign, these fibromas, and they're the most common sex-scored stromal tumor. They're solid masses. They tend to be fibroblast and collagen composed, and they might have calcification, which makes it harder to differentiate from a fibroid, since those can also calcify. But on ultrasound, it will look like a hypoechoic mass with posterior shadowing. On CT, it's often a homogeneous tumor that can have delayed enhancement, which is typical for any fibrous tumor, the delayed enhancement. And on MRI, just like other fibrous tissues, they tend to be hypointense. Here's a different fibroma showing on T2, it's dark on T2, but we do have some T2 areas of hyperintensity that don't correspond to fat because they remain bright on the T2 fat suppressed series. And that's because large fibromas might have this intratumoral edema, and they can also have cystic or myxomatous degeneration. And is this cystic degeneration or myxomatous, do you think? Well, here it's T2 bright and it's enhancing. So that tells you it's not cystic, otherwise it would not enhance. So that's myxomatous degeneration. It also, this could look identical to a fibrothecoma because the thecoma component can be T2 bright and enhanced as well. I'll talk about thecomas in just a moment. But first, what do you think about this case? We have a large mass on T2 weighted images, axial here, and this is sagittal. Here's the right ovary, and then there's the uterus. So is this arising from the ovary or the uterus? And is there a clue that helps you? Well, we don't see a great claw sign, but the ovary is so compressed that it's hard to say maybe there is one and it's just partially effaced. So, but the clue is in this interface here. So if we zoom into that a bit, we have the bridging vessel sign. And when you have an exophytic uterine fibroid, those will tend to be fed by vessels from the uterine arteries. So you'll see these flow voids that pass between the myometrium here and the mass. And then sometimes you'll see those better on T2 weighted images, sometimes better on T1, but it's this serpentine collection of these flow voids. And on axial images here with contrast, there's the uterus, and then this is the mass here, and we're seeing this tangle of vessels in between them. They're bridging the mass and the uterus. And you can even see that on ultrasound, but it's much harder unless you're specifically looking for it. Here's the uterus, the bridging vessel sign, and then this is the mass. So this is typical for a fibroid. And we can say that with high specificity because of that bridging vessel sign. So when you have an ovarian fibroma, those are usually fed directly from the ovarian artery, not from the myometrial vessels. So you won't tend to see this sign, even if it's a large fibroma impressing upon the uterus. So look for that bridging vessel sign. Now, this is a different patient, a 73-year-old female with postmenopausal bleeding. And you can see the endometrial stripe is mildly thickened. It measures about 7 millimeters, which is abnormal for a bleeding postmenopausal patient. It also has some cystic changes, and then the myometrium also looks heterogeneous with a few scattered myometrial cysts. And on further scanning, this homogeneously hypoechoic solid left ovarian mass was identified. And this turned out to be a fibrothecoma. And it was secreting estrogen, which was causing this endometrial thickening and actually some adenomyosis found on pathology. So if it's a pure fibroma, it has no estrogenic activity. But if it has any thecomatous tissue, like a fibrothecoma or a pure thecoma, then it will. And thecomas will often secrete estrogen, causing this hyperplasia or even carcinoma. And these tumors tend to be solid, just like fibromas, and it's not usually possible to differentiate it from a pure fibroma on imaging. But it's something to think about if you do have endometrial stripe thickening. So now we have two tumors that can be associated with endometrial stripe thickening, right? We have a fibrothecoma and the endometrioid carcinoma. So there are some other syndromes associated with fibroma. One is this, there's a large solid hypoenhancing mass here in the pelvis on CT. And we see when we look further up, there is also some ascites and a left pleural effusion. So when you have a fibrous tumor, ascites and pleural effusion, that suggests Meague syndrome. And the cure for that is to just remove the tumor. That'll tend to resolve. And then fibromas can also be part of the basal cell nevus syndrome spectrum, also known as Gorlin syndrome. So that's something to keep in mind when evaluating those patients. Now here's a potential mimic. This patient presented with this ovarian mass. Here's the uterus, and then the mass here on transverse and sagittal imaging. And it looks hypoechoic and solid, and it's not very vascular. So it might be reasonable to question whether this is an ovarian fibroma, especially if the patient's not complaining of active pain. This patient had an MRI, and you can see it's T1 hypointense. But then on T2 weighted images, it's very bright. This is the mass right here. And here's the normal left ovary. This is involving the right ovary. And here's the uterus. And there's also a small amount of fluid here in the pelvis. And then on this sagittal T2 fat suppressed image, you can see that mass is extremely bright. So is that typical for fibroma? Well, no, those tend to be very hypointense, right, on T2 because of the fibrous tissue. But then you might argue, well, could it be a thecoma? Because those can be bright. But then when we give gadolinium, we don't really see much enhancement. There's just some slight heterogeneous peripheral enhancement on axial and sagittal. And this is actually an example of chronic right ovarian torsion. And this can sometimes be misdiagnosed as an ovarian mass because, especially if the patient doesn't have acute pain because it's chronically torse. But just keep that in mind. Look at all the elements. Fibromas and even thecomas will usually have some hypointensity on T2 and should show some delayed enhancement. All right, so moving on to a different patient in this category. Here we have a patient that also has postmenopausal bleeding and endometrial hyperplasia. You can see the endometrial stripe thickness here is about 2 centimeters. And then here we have a mixed cystic and solid mass. And again, we're confirming that there's flow within it. We have some spectral Doppler showing a waveform. And this is an example of a granulosa cell tumor. So this is actually the most common malignant sex cord stromal tumor. So fibromas are benign, the most common sex cord stromal tumor, but this is the most common malignant tumor. And these predominantly occur in peri and postmenopausal women. So you can remember it by thinking of granulosa is seen a bit more common in grandmother. So you can also remember that it's the most common or grandest tumor that produces estrogen. So it's the most common ovarian tumor to produce estrogen. So like thecomas that we talked about, it can also cause endometrial hyperplasia or carcinoma. And even though these are more common in older patients, they can occur in children. And when that happens, because of the hyperestrogen state, it can cause precocious puberty. And here's a different patient, 71-year-old female with pain and bloating. We have this multilocular mass with thick septations and solid components. And these can have a variable appearance. So the one I just showed you a moment ago was a bit more solid. This one is more multilocular and cystic. But the clue is they tend not to have these papillary projections that we saw with the epithelial ovarian tumors. The solid parts are usually more confluent or related to septal thickening. So this is the same patient, her CT scan showing that it is a multilocular cystic and solid with these thick septations and confluent soft tissue, but we don't see papillary projections. But your differential for this would, of course, include mucinous cystadenocarcinoma, because that could look quite similar. But if you also saw endometrial stripe thickening, that would cause you to lean a bit more towards granulosa cell tumor. And this tumor looks quite similar, doesn't it? We have a multilocular cystic mass with these irregular thick septations and possibly some solid components. But the difference here is this is a 15-year-old female compared to a postmenopausal patient. Here's some internal vascularity there. And when we look at the MRI, what do we see? Here's the sagittal and axial T2. There's the uterus here. And this is the multilocular cystic mass causing some mass effect against the bladder. And it has some solid components that enhance on post-contrast imaging, as well as this irregular thick septations and these kind of intratumoral cysts. And again, without any history, seeing this has kind of a stained glass appearance. You might also include mucinous cystadenocarcinoma in your differential. However, that would be less common in a 15-year-old, because remember, those tend to occur more in the 6th to 7th decade of life. Could be a borderline tumor, though. But this ended up being a Sertoli-Leydig cell tumor. So most of these tumors, unlike granulosa cell tumors, these are usually benign. About 10 to 20% can be malignant. And sometimes these are treated as a low-grade malignancy. They typically occur in young patients, though, usually of reproductive age, classically under age 30. And they're not very common, but they are actually the most common virilizing tumor, so the most common androgen-secreting tumor. So just like granulosa cell is the most common estrogen, this is the most common androgen-secreting tumor. And up to half of these will actually secrete androgens or testosterone. Another rare virilizing tumor, less common than even this, is steroid cell tumor. So the take-home point for that is, usually when we're imaging the pelvis in a patient with virilization, the most common thing we see is polycystic ovarian syndrome. But keep in mind, there are tumors that can also do that. So like the Sertoli-Leydig tumor, the rare steroid cell tumor, and then as I mentioned, dermoid cysts can very rarely secrete testosterone. So just something to keep in mind when you're doing your imaging evaluation. Look at the ovaries for more than just cysts. And so these can have a variable appearance, but they often will appear as a well-defined enhancing solid mass with intratumoral cysts. So just to summarize those two tumors, the granulosa and Sertoli-Leydig, the granulosa cell tumors are malignant, but the Sertoli are usually benign. Granulosa is the most common estrogen-producing tumor, whereas Sertoli is the most common androgen-producing tumor. And because of that, granulosa cell can cause endometrial thickening, but you won't see that with Sertoli-Leydig. And granulosa cell more common in peri or postmenopausal patients, but we see Sertoli-Leydig in younger patients, usually less than 30. All right, so that's a lot of information. I'll just summarize some of the key points to differentiate different tumors. So where are the ovarian neoplasms with associated thickening of the endometrial stripe? The fibrothecoma and thecomas, which can be solid. The granulosa cell tumor, which can be solid or mixed cystic and solid, and both of these will secrete estrogen. And then the endometrioid carcinoma, which again can occur, is the most common tumor to occur in the setting of endometriosis, can be bilateral. And then the endometrial stripe thickening is not due to estrogen secretion, but it's due to a synchronous endometrial hyperplasia or carcinoma. So which tumors tend to be bilateral? So dermoid cysts, about 10%. Serous epithelial tumors can be bilateral, whether they're benign or malignant. Endometrioid carcinoma, in about 30 to 50%. And then I didn't talk about it, but metastases can also be bilateral. And we could also include endometriomas, even though those are not neoplasms. And then ovarian neoplasms that can calcify, dermoid cyst often calcifies. It might have a tooth within it. Serous epithelial tumors can have that pseumomatous calcification in about 12%. And then fibrothecomas can also calcify, just like fibroids. And then Brenner tumors, that's usually a hallmark. Remember, they're small, less than 2 centimeters solid, and often calcify. And there's one there. All right, and those are some of my references if you'd like to read more on ovarian neoplasms. And thank you very much for your attention.
Thank you very much, Dr. Kowal, for this very informative session.
Sure, my pleasure.
Yeah. I think we have some questions. Do you have some time if you can answer? Would you like me to read them for you, or would you like to read the questions if your time allows?
Let's see, I'm pulling them up now. Yeah, actually, I'm not. Oh, there we go. Sorry. So which modality do you use for following metastatic malignant ovarian neoplasms undergoing chemotherapy? Let me just pull this over, sorry. And what is the time interval for follow-ups? Yeah, that's a good question. Whoops. Sorry, I'm having a computer malfunction. Okay, there we go. Yeah, we often, that will often use
emergency services directly from your phone. Otherwise, I can help you with specific questions or how to connect to Bluetooth.
Sorry about that. My Amazon was starting to answer my question.
Okay.
I've unplugged it.
It's
Yeah,
okay.
we often will use PET-CT for follow-up if we're staging the patient for extent of metastatic disease for like omentocarcinomatosis or lymphadenopathy. And then once the disease has been narrowed down to the pelvis, we might use MRI to look for any residual disease, or if there's recurrence at the vaginal cuff or elsewhere in the pelvis as a problem-solving tool. And let's see, what is the protocol for follow-up by imaging after surgical treatment of cases with serous cystadenocarcinoma? So it depends on the patient age and the grade of the disease. And let's see. So like the calcified cases I was showing you with the pseumomatous calcification, those are actually tend to occur more with the low-grade tumors. So the follow-up is usually not as aggressive as patients who have like massive debulking of surgery. So it kind of depends on your institution. Oh, how to differentiate between hemorrhagic cyst and endometrioma. So I almost included that because that is a difficult question. That's a good question. So one is just time interval. Endometriomas will stay around forever until they're removed, but hemorrhagic cysts tend to resolve within 8 to 12 weeks. So just doing a follow-up ultrasound can often help with that. But if you're reading an MRI, though, the endometrioma should be homogeneously T1 bright, whereas hemorrhagic cysts will be mildly T1 bright and often a little heterogeneous. And then the hemorrhagic cyst will usually also be T2 bright as opposed to endometriomas, which will be T2 dark. So those are clues to differentiate the two. How to deal with sizable simple cyst during pregnancy is aspiration an option? Yeah, that's a difficult question too. We often encounter that where patients are pregnant and they're undergoing follow-up imaging. Often we'll use ultrasound for that because we have, if we do an MRI, we'll do it without gadolinium, since gadolinium is generally contraindicated as it can cross the placenta. And if it's a slow-growing cyst, it will often just be followed. But if it's something that if it's aggressively growing and will threaten the mother's life, then that may then we might do more aggressive imaging, or the patient could potentially go to surgery. And aspiration, I've seen that done a few times. Usually, though, it's just the cyst is usually just followed. Let's see, for imaging of ovarian and adnexal lesions, should we just stick to the ORADS classification and referral, or resort to another imaging modality? Or should we suggest differential diagnosis of lesion on ultrasound basis? Yes, I didn't really talk about ORADS. There's another question on ORADS. The ORADS has a lot of useful classification points. We often use ORADS for the follow-up of like benign lesions. Like for hemorrhagic cyst, ORADS recommends 8 to 12 week follow-up if it's more than 5 centimeters, and less than 5 centimeters, no follow-up. Or for tumors that appear to be most consistent with teratoma or endometrioma, to do an initial follow-up in 8 to 12 weeks, and then maybe yearly if MRI or resection is not done. But it kind of depends on your institution whether or not ORADS would be indicated. And it's different. So I know in other countries too, the IOTA classification is used a bit more commonly than just ORADS. They do complement each other. One issue that we sometimes face with ORADS is for the higher grade lesions like 4 and 5, the next step in management is not really clearly defined as far as whether it should be MRI or GYN oncology follow-up. It just kind of gives a multiple options for that. So that's why often it kind of, at our institution, usually GYN oncology gets involved and they decide whether or not we need an MRI. If the serous cystadenoma has calcification, can we say it is osseous metaplasia in an ovarian tumor? I think it's probably better to just say ossification or calcification, because the way the calcification forms might not always be metaplasia. Like we can get osseous metaplasia in a renal cell carcinoma, that can rarely occur, but the type of calcification that occurs in serous cystadenoma is usually this pseumomatous calcification. Let's see. All right, are there any other questions? I'm happy to take any verbal questions if we have time.
I think you've covered most of the questions, and we really appreciate your effort and your time today.
Sure, thanks
And
for
we'll
having
look
me.
forward to seeing you again, hopefully.
Yeah, that was a lot of fun.
Yeah, we'll definitely follow your YouTube channel, but we'll be very pleased if you give us another lecture, hopefully.
Great.
Thank you very much for your time and effort. Thank you.
Thank you very much.